So management in anything, and then again, you can see that the way you address a symptom is very easy, related to the disease, not related to the disease, and something else, totally something related to the treatment of the disease. The same for the management. You always have two types of approach. A general type of approach that deal with everything other than meds, and then the medication approach. So, so explain to the patient what's going on. It's a very disturbing, I don't know if any of you did have some nausea, probably all of us, because we all have some GI disturbances, but it can be very annoying, and especially if it is prolonged and it's going on, because first of all, if you are nauseated or / vomiting, you are not eating, you lose weight, and then it's become troublesome. So I think that what we can do as a general approach, improve the environment. You know, if it smells terrible, smell of certain food can cause just nausea. You just have to notice in this hospital, some days it's not very great. Avoid rapid movement. If a patient tells you that the movement is something that really triggers, of course, we should pay attention to that. Hydrate as much as appropriate it is. Again, we have limitation in advanced cancer because patient cannot take too much, so we need to see if we should supplement by some form of hydration. Progressive alimentation, so it's good sometimes to have the nutritionist who will give us a clue what to give the patient. There's so many things on the market nowadays, it keeps changing. Good mouth care. Oftentimes, you know, we examine our patient and that's not very good. If your mouth is so filthy, either the teeth, the tongue, or whatever it is, it doesn't help because, of course, the taste will be altered. Correct all contributory factors, constipation, anxiety, disturbances that you have in your metabolites, whatever you can correct. And of course, sometimes it's not correctable. Therefore, you have to live with that and just do symptom control because you cannot correct the cause. And adjust the medication appropriately. Really pay attention to the antibiotics. We throw a lot of antibiotics, 4 antibiotics, sometimes more or less without reason. We discovered that finally they were never a positive culture. They were started this way. And we realized, oh, after a week, nothing is growing, and patients still on 3 or 4 antibiotics with a lot of side effects. Those antibiotics are not without side effects. So now let's look and pay attention to the pharmacologic approach of the nausea. If nausea, the same principle that you apply for pain are applicable for that. If the nausea is once upon a time, one in the blue moon, one every second day, well, PRN medication will be sufficient. But if the nausea is persistent, you have to have something around the clock. And sometimes breaking the cycle for a day or two, something around the clock, will alleviate the symptoms, and the patient will feel so much better. After that, you can try to space this out. But usually, if it is persistent, they should be on persistent, on around-the-clock medication. If, again, the medication that you are going to use, and sometimes we see that patient have nausea / vomiting, and we give PO meds. Well, how good this is. I mean, you know, if you are nauseated, even though if you don't vomit, you may not feel like taking too many pills. So therefore, the route that you are going to use for your antiemetic is very important. Use alternative route for patients who have too nausea or have vomiting. You may need to go with parenteral route. You may need to take PR route, depending of in what setting that you are, depending of what you do have also as comorbidities in your patient. In intractable vomiting, sometimes, and it's a little bit like the pain, we need to maybe combine a few drugs to play on different centers. As you saw in the pathophysiology, all those drugs have a role on different receptors. Therefore, it is good sometimes to combine 1 or 2 to play a role onto different zones of your pathophysiology. So here are the antiemetics, and on the left side you have some clinical characteristic, the cause of your nausea, and on the other side, on the right side, you have what you should consider if it is the cause. And that's also very exemplified on the sheet that I gave you about the pathophysiology and the antiemetics used for nausea. So if you think that your nausea and vomiting is due to drugs, to metabolic changes, probably that your best bet or your best medication to use will be something in the neuroleptic class or the 5-HT antagonist. If you think that has to do with vertigo, this is why the questionnaire is so important. If it has to do with vertigo, probably the antihistaminic, the anticholinergic, or the benzo will be your best bet. I remember having many, many years ago patients that even GI was consultant for this patient who has severe nausea, could not eat anymore. That was going on for a while. He has been tried on all the antiemetic except one, and that was meclizine, the antihistaminic. And how we discovered that, we asked him just one question. How is that when you move around? Do you have any type of vertigo? And he happened to answer yes. So we started the meclizine, and that was miraculous. I mean, at the end of the day, he was free of his nausea. That worked very, very, very well. So that's why the questionnaire is important. Nausea, vomiting with early satiety. A patient who will tell you, well, it's stuck there. Remember, we ask oftentimes the question, do you have a sense that things are not going down? They are just behind there? Yes. Do you feel full very early on? Yes, easy. That is to say that this patient probably, and especially patient on opioids, as you know, opioids slow down the gut from the mouth to the anus, and so not only it causes constipation, but also slow down in the upper GI tract. And so for that, one of the best agents will be a prokinetic agent. There's not much left on the market as prokinetic. I think there's only the Reglan metoclopramide. They used to have the Cisapride, who was working well on the lower GI, but it's out of the market for the last 5, 6, 7 years, I think, a long time ago. So nausea, vomiting with anxiety, we already discussed that. The benzo will be your best ally. CNS lesion. So if you think patients wake up in the morning and say, well, my God, I have a projectile. Remember also the character of the vomiting. Projectile vomiting early in the morning associated with headache, well, don't go further. Start your corticosteroids, then investigate, because probably that is something to do with the CNS, and you will have probably good relief with that. Of course, scan and look what's in the head of your patient. Nausea, vomiting with advanced illness. So you will have a lot of nausea, vomiting, and patient oftentimes will complain, I have kind of pain in the right upper quadrant. They are known to have liver mets, and they oftentimes will be associated also with some smell, the smell and things like that. The minute I smell the food, wow, ooh, I don't feel well. Think about distension of the liver capsule. And probably that some of the nausea is due to the liver involvement at this point in time, and the steroids may be a good ally, a good treatment to use for this type of patients. So you have now your agent. There are many agents in each class. It's up to us to know them and become familiar with one or the other. Is there anyone better than the other? No, not really. Keep in mind that also there's another principle in palliative care. If you have, example, a patient who had nausea but at the same time is very agitated, maybe you will go with the haloperidol, with the Haldol, because not only it's an antiemetic but also it's an anti-agitation medication. Therefore, you maximize your symptom control by using less and less drug as possible. In the anticholinergic drug, you have atropine, scope. Be careful with the anticholinergic drug. They are great. They can cause some sedation, and they will slow your gut down. So if you have a patient with nausea, but at the same time has severe constipation, that will not be the drug of choice. This is why when you use any drug that you are going to use, you have to look at the overall picture and the other symptoms of your patient. The antihistaminic, we have 3, maybe there's some more also. This is not extensive. You may find some other prokinetic agents. We talk about that. And 5-HT antagonists. So there are many more on the market. We started with the ondansetron, I think was the first one. but now there are many on the market. They are much more expensive than the others. Therefore, it's never the first line, unless you have patient who is on chemo radiation therapy. So when I see that everybody comes to from other floors, from acute floor or from other institution on a densitron, if you try the others and they does not work, that's fine. But it's rarely the drug of first choice.